Hello, everyone. Today we're going to be talking about psychopharmacology related to the psychiatric mental health nurse practitioner exam. So the concepts in psychopharmacology management include the study of what drugs do and how they do it. There are two terms that you should know. So first is Pharmacokinetics, and this is the study of what the body does to the drug. The way I like to remember this is the word kinetics has to do with the body. So it's what the body does to the drug, and this includes things like absorption, distribution, metabolism, and excretion, because those are all things that the body does. Then there's pharmacodynamics, and when we think of the word dynamic, it's kind of like the way that something moves, I guess, is kind of how I think of it. So the study of what the drug does to the body. So like the dynamic of the drug. That's the way I remember it. I think it's easier to just remember that kinetic has to do with what the body does with the drug. So then you know that psychodynamic is what the drug does to the body. So this has to include things like target sites for drug action, including receptors, ion channels, enzymes, and carrier proteins. So when we talk about pharmacokinetics, so this is again what the body does to the drug because of the kinetics. So the first one is called absorption, and this is the method and rate at which a drug leaves the site of administration. So with oral medications, absorption normally occurs in the small intestines and then travels through the liver. Distribution occurs after the drug leaves the systemic circulation and enters into the cells, and the drugs are redistributed in organs according to their fat and protein contents. And most psychotropic medications are lipophilic and highly protein bound. Metabolism is the process in which the drug becomes chemically altered in the body. There is something called first pass metabolism, and this is the process by which the drug is metabolized by cytochrome P450, and you're going to hear about this cytochrome a lot while you are studying for this exam. In this cytochrome P450 is an enzyme in the intestines and liver prior to going into systemic circulation. And then elimination is the process by which the drug is removed from the body. Just to hop back, the first pass metabolism. So this is really a process where the drug is metabolized by that cytochrome P enzyme in the intestines and liver prior to going into systemic circulation. So first pass metabolism makes the drug lower in the body, kind of like the first time you take it. And then, so you might remember these things from nursing school. So a half-life, this is the time it's needed to clear 50% of the drug from the plasma. And the half-life also determines the dosing interval and the length of time to reach a steady state. And steady state is the point at which an amount of the drug is eliminated between doses is approximately equal to the dose administered. And drugs usually are administered once every half-life to achieve a steady state, and it takes approximately 5 half-lives to achieve a steady state and 5 half-lives to completely eliminate the drug. So there are different alterations in pharmacokinetics. So again, what the body does to the drug. Again, we're talking about this cytochrome P450. So hepatic cytochrome P450 enzyme interactions can induce or inhibit the metabolism of certain drugs, therefore changing their desired concentration level. Approximately 10% of Caucasians are poor metabolizers of P450-2D6 enzyme, and approximately 20% of Asians have a reduced activity of the P450-2C19 enzyme. And first pass metabolism activity of the P450 enzymes. And these are all different types. So you have your 2C9, your 2C19, your 2D6, and your 3A4. In young children may exceed rates of adolescent and adults and give rise to underexposure to certain medications. So again, we talked about that first pass metabolism. It kind of like uses up the drug really fast, I guess, or it's metabolizing the drug, creating lower levels in the blood. And in children, that's what this is saying. Sorry, that was my dog sneezing. In children, it can have excessive rates. So the medication doses can be lower than they need to be. So that's talking about the underexposure to certain medications. Conversely, in this certain pathway, the 1A2 pathway, it is delayed, possibly leading to toxic effects from the drug. You don't really need to remember all the different pathways and how they are in children versus adolescents versus adults. These are kind of like just fun to know facts. Liver disease will affect liver enzyme activity and first pass metabolism, possibly resulting in toxic plasma drug levels. Kidney disease or drugs that reduce renal clearance, such as non-steroidal anti-inflammatory drugs, may increase serum concentrations of the drug that are excreted by the kidneys. And older adults have more body fat and less protein. They are more likely to develop toxicity due to the accumulation and erratic blood levels of the drug. That is important to know, that older adults have higher levels of body fat and less protein, and they can become toxic from drugs due to this, and that's why they usually need lower doses. So enzyme inducers. So an enzyme inducer can decrease the serum level of the drug. And the way I like to remember this is if we think of an inducer, right, that makes things more higher, right? Inhibit is when it's blocked. Induce is when it's induced. There is more of it. So if we are inducing the enzyme breaks down the drug. So there's actually lower levels of the drug. So that is how I remember that. So enzymes inducers decrease the serum level of other drugs that are substrates of that enzyme, thus causing subtherapeutic drug levels. An example is that tobacco and carbamazepine. So if a patient starts smoking, tobacco is an enzyme inducer. So they start smoking, we're going to need to increase the dose of the medication because tobacco is going to be an enzyme inducer, which is going to lower the level of the drug, in this case, carbamazepine. So we have to increase the dose. However, if a patient stops smoking or they start a smoke cessation program, we're going to need to decrease the dose because now that enzyme is not being induced by the tobacco. So an example, a patient starts olanzapine, comes to the next appointment and states that they started smoking. So this means because tobacco is an enzyme inducer, it will decrease the serum level. So you need to increase the dose. If the patient comes back a month later and they started a smoking cessation program, then you should decrease the dose. Now you're going to have to remember what is an enzyme inducer and what is an enzyme inhibitor, and we're going to go through that. So enzyme inhibitors, I know it says inducer at the top, but now we're moving on to inhibitors. These can increase the serum levels of other drugs that are substrates of that enzyme, thus possibly causing toxic levels. So an example is clarithromycin and ketonazole. I'm not exactly sure how you say that. If they start taking a drug and the patient is introducing an enzyme inhibitor, so now we are inhibiting the enzyme. We are not letting it be that high because we're inhibiting it, which means we're going to have higher levels of the drug because the enzyme is not breaking it down. It will then increase the serum levels, so you have to decrease the dose. So what are things that inhibit or induce this cytochrome P450? This is like one of the main ones that we do need to know. And we do need to remember the inhibitors and the inducers. You'll probably get a question related to this. So inhibitors are bupropion, clomipramine, ciminidine, clarithromycin, fluoroquinolones, grapefruit and grapefruit juice, ketonazole, nefazodone, and SSRIs. So again, if it is an enzyme inhibitor, it's going to cause the dose to be higher in the blood because we're inhibiting that enzyme that breaks it down. Things that are going to induce this enzyme, the cytochrome P450. So if we are inducing it, we are increasing the levels of the enzyme and we are therefore decreasing the level of the drug because the enzyme is breaking down the drug. Things like carbamazepine, St. John's wort, phenytoin, phenobarbital, and tobacco. So when we talk about cytochrome P1A2, you do not need to remember all of these. The main point that you need to remember is that cytochrome P1A2, a substrate, is clozapine. So that's kind of like the big one. And the inducer that you need to remember related to this is tobacco. So again, if we have something is an enzyme inducer, we're increasing the enzyme. and therefore decreasing the level of the drug, meaning that if patients are taking clozapine and they are smoking, they are going to need higher doses because tobacco smoke is an enzyme inducer. Okay. And that's it. Don't remember all the other things on there. Just remember clozapine, tobacco. All right, so when it comes to enzyme activity, so liver disease will affect liver enzyme activity and first-pass metabolism, possibly resulting in toxic plasma blood levels. Kidney disease or drugs that reduce renal clearance, such as nonsteroidal anti-inflammatory drugs, thiazides, and ACE inhibitors may increase the serum concentration of drugs that are excreted by the kidneys, so such as lithium. So when patients are prescribed lithium, we typically don't want to give them like NSAIDs or ACE inhibitors. We just want to be mindful of that, or just be mindful of like the dosing. And then older adults are more sensitive to psychotropic drugs because they have decreased intracellular water, a decreased protein binding, meaning that there is a decrease in protein available for binding. There's free or active drug remains in the body, which can predispose older adults to toxicity. They have lower muscle mass, decreased metabolism, and increased body fat concentration. So when we talk about pharmacodynamics, so types of drugs and how they affect neurotransmission. So different types of drugs, we have things that are full agonist. So this drug is going to bind to the receptor and activate a biological response, and it's going to mimic the effects of the neurotransmitter. So in slides coming up, when we have the name of drugs, we're going to have these boxes that have different signs up in the corner. So for example, the plus sign, this is going to indicate that it's a full agonist. So if in this box you saw something like an S, that's going to stand for serotonin, which would mean that the drug is a full agonist of serotonin. So that means that it's going to mimic the effects of serotonin in the body. And we have a partial agonist. So this mimics the effect of a neurotransmitter, but only to a certain point. So for example, something like Suboxone, where it is mimicking the effects of like an opioid, but it's only to a certain point. It's not fully stimulating that receptor. Then we have a neutral antagonist. This blocks the effect of a neurotransmitter. So this would be something like Vivitrol. Vivitrol will come in, it will lock into that opioid receptor, and it will essentially block it from allowing any other opioids to attach. But it doesn't stimulate, it just blocks. And then we have an inverse agonist. So this causes the opposite effect of a neurotransmitter. So this could be something like Narcan, where it's causing the opposite kind of action. All right, so pharmacodynamics. So again, this is how the drug is working in the body. And we have to look at sites of drug action. So there's ion channels, which exist for many ions, such as sodium, potassium, chloride, calcium, and can be open at some times and closed at other times. There is an excitatory response. So something called depolarization involves the opening of a sodium and calcium channel so that ions can get into the cell. And then there is an inhibitory response, which is a repolarization, which involves the opening of a chloride channel. So chloride goes into the cell and potassium leaves, or both. There are enzymes, which are important for drug metabolism and play an important role in chemical alterations in the body. And there are carrier proteins or reuptake pumps, which transport neurotransmitters out of the synapse and back into the presynaptic neuron to be recycled and reused. So different terminology you should know. Potency is relative dose required to achieve certain effects. There is a therapeutic index. This is the measure of the toxicity or safety of a drug. The ratio of the medium toxic dose to the medium effective dose. So for example, something like drugs with higher therapeutic indexes have a high margin of safety, and that is a therapeutic dose and toxic dose are far apart. And then drugs with a low therapeutic index have a low margin of safety, and that is when the therapeutic dose and the toxic dose are close together. So for example, something like lithium. Lithium has a very low therapeutic index. So the dose that is therapeutic is very close to the dose that is considered toxic. So just something to think about. And then tolerance, so the process of becoming less responsive to a particular drug over time. We know patients can build up tolerance to things like benzodiazepines. A dose that once worked over time may not work, and they might need a higher dose. Tachyphylaxis is an acute decrease in a therapeutic response. All right, so these are all the things that the psychiatric mental health nurse practitioner manages related to pharmacology. We make diagnoses, we consider the phase of the illness, we look at personal history, the client's motivation, looking at interactions between medications, identifying cultural implications, looking at risks and benefits, monitoring, understanding how we're going to target different symptoms and alternatives. We provide follow-up, standards of care, relapse planning and prevention, determining the length of treatment, use standardized scales and evidence-based practice, and we monitor for non-adherence. So when talking about controlled substances, Scheduled 1, these are non-medical substances with a high abuse potential. They're used for research purposes only, and they're not legally available by prescription. So for example, something like heroin. A Schedule 2 controlled substance is a medical drug in current use. It has a high potential for abuse and dependency. It can only be given by a written prescription, no telephone orders allowed, no refills allowed on prescriptions. And these include things like morphine, codeine, fentanyl, methadone, hydromorphone, hydrocodone, oxycodone, amphetamine salts, and methylphenidate. Scheduled 3 are medicinal drugs with less abuse potential than Schedule 2, but a greater potential of abuse than Schedule 4. Telephone orders are allowed. Prescriptions can be renewed every 6 months. Refills are limited to 5, and these include things like appetite suppressants, testosterone, Suboxone, and things like that. Schedule 4 has less abuse potential than Schedule 3. Here are all the examples for Schedule 4. A lot of benzos in there, modafinil, zolpidem, Lunesta, all of those. And then Schedule 5 is handled in a manner similar to non-controlled substances. It has the lowest abuse potential, and these are things like buprenorphine, Robitussin with codeine, promethazine with codeine. So psychotropics can induce depression or mania. So for example, there are medications in this world that can cause people to have changes in mood related to depression or mania. So medications that can induce mania are steroids, antabuse, INH, and people who take antidepressants but have underlying bipolar disorder. All of those things can cause people to have mania. Medications that can cause depression include steroids, interferon, beta blockers, tretinoin, retroviral drugs, anti-neoplastic drugs, benzodiazepines, and progesterone. Also, when people take drug tests, it's very interesting that there's a lot of medications that are can cause false positives on drug tests. So a false positive for amphetamines can come from stimulant medications, bupropion, fluoxetine, trazodone, ranitidine, Serotonin, nasal decongestants, and pseudoephedrine. Alcohol can pop up positive for people taking Valium. Benzodiazepines can become positive for people taking Zoloft. Cocaine can indicate positive for people on amoxicillin, most antibiotics, and NSAIDs. Heroin or morphine can be positive from quinolones, rifampin, codeine, and poppy seeds, and methadone or PCP can show as a positive for people taking over-the-counter cough medicine like NyQuil or dextromethorphan. So in the body, we have different neurotransmitters and neurotransmission. So here are a list of the neurotransmitters. So we have adrenaline, which is our fight or flight. Noradrenaline is our concentration. Dopamine is our pleasure, serotonin is our mood, GABA is calming, acetylcholine is learning, glutamate is memory, and endorphins help with or cause euphoria. So there's 3 rules of neurotransmission. So the first one is what goes up must come down, and also what goes down must come up. So for example, this has to do with intoxication and withdrawal. So when people take something like a stimulant, like cocaine or amphetamines, when they're intoxicated, they are amped up, right? They have increased confidence. They have a lot of energy. They're going a mile a minute. But when they withdraw, we're going to see the opposite. So they're going to feel sick. They're going to be tired. They're just not going to be feeling well. And then It's the opposite when we add a depressant. So when people take something like benzodiazepines, also alcohol is technically a depressant. I'll explain a little bit about that in a second. When they are intoxicated, right? You think people take a benzodiazepine and they get sedated, they get tired, they get relaxed, it gets rid of anxiety. But then when they are withdrawing off of those substances, we are going to see the opposite. So they're going to be having increased anxiety, agitation. They're going to be sweating. They can have seizures, which is a huge problem. And you can think of too, like benzodiazepines are the treatment for seizures, right? It's the opposite. Alcohol is actually a depressant. A lot of people get confused because you can think if you've drinking alcohol or witnessed other people drink alcohol, it can make people do things they wouldn't normally do. This is called inhibition. So it does cause inhibition, which causes people to do things they wouldn't normally do when they drink. However, in our brain, it is actually a depressant. So that sometimes can be confusing for people. But when people are withdrawing off of alcohol, we do worry about seizures because of this opposite action. And this is because neurotransmitters are not easily fooled. So they use two different mechanisms to kind of create that homeostasis in the body. So when people are taking a drug that is going to decrease the neurotransmitter in the body, what happens is, and we can see this here, these neurotransmitters or the cells are adding more receptors. So we can see they're adding more receptors because they're looking to get more neurotransmitters that now have reduced in that space. And this is called something called upregulation. And this is fine. It maintains homeostasis. It works for the body, but becomes an issue when the person stops taking that drug. And now there is an increase of that neurotransmitter because now that cell is way too overstimulated because there are way too many receptors in the space. Then downregulation is the opposite. So if we take a drug that increases the neurotransmitters, so we can see all these yellow dots, there's more of them, right? The synapse will start to remove receptors. So we can see there's less receptors here. And that way it's not too overstimulated by all the neurotransmitters that are there. And that's fine and works, but then becomes an issue when you take the drug away that is causing the increase in neurotransmitters because now there's a reduction in the amount. And now the synapse is not getting enough stimulation. So yes. And then with great power comes great responsibility. So we don't always use the most powerful drugs first. We always want to think about safety, and starting with the most least powerful option is usually how that occurs, and then moving to more powerful as needed. All right. So we went over this. So what different neurotransmitters do in the body? So the first one is dopamine. This has to do with our drive reward system, plays a role in psychosis. Too much dopamine can cause psychosis. Plays a role with Parkinsonism. When we don't have enough dopamine, we can actually induce Parkinson's. Parkinson's disease naturally is too little dopamine, so that kind of makes sense, right? It plays a role with attention, motor behavior, inhibition of prolactin, plays a role with narcotics, and then extrapyramidal movements. And we'll get into how all this relates. Serotonin plays a role with our satisfaction. It's linked to socialness, also linked to migraines, decreases in anxiety, decreases in impulsivity, decreases in sex drive. So these we see like the positive and negative here. Plays a role with erythrocytes and binding, and so can increase bleeding if there's more of it. And nausea and GI motility. So fun fact, Zofran actually blocks serotonin and therefore it helps with nausea. And when we talk about benefits versus side effects of different drugs, this will be helpful when we know what those drugs change. And that's why instead of knowing each drug and each side effect, if you know what the class of drug is, you can mostly sort of know what the side effects are, which we're going to talk about. So a big side effect we have to watch for is when serotonin gets too high. And this can happen if people are taking drugs that affect their serotonin, for example, like an SSRI, and then say they start taking St. John's wort or an herbal supplement, or they're switching from one SSRI to another. They can have too high levels of serotonin, and they can have something called serotonin syndrome. We're going to talk about 3 main side effects with psychotropic meds that you need to watch for, or not main, but kind of like the high risk. The thing that's interesting about them is they present very similarly, and really the way to differentiate which one it is to look at what medications the patient is taking. There are some subtle differences, but if you can just know the main kind of side effects that that's like a red flag thing. And we're going to go over that. That is what's important. So for example, dilated pupils, all three of them are going to have dilated pupils that we talk about. You're also going to see kind of like the agitation, possible confusion, tachycardia, sweating, hyperreflexia, things like that. The way we can remember serotonin syndrome is head, red, and dead. So they're going to have headache, agitation, confusion. They're going to be hot, hyperthermia, hypertonia, sweating, tachycardia. And again, this is very similar to a lot of the other ones we're going to talk about, you'll see. And if this goes untreated, it can have a mortality rate between 2 to 12%. So pretty high. So these are things that we need to be able to identify. So the next neurotransmitter is norepinephrine. This is our flight or fight response. And we can think if we were being chased by a lion, that feeling we would feel, that is norepinephrine. Then we have glutamate and GABA. So the way I like to remember these is that glutamate is like our on switch and GABA is like our off switch. GABA helps us to relax. Benzodiazepines work on GABA. It kind of like brings us down, makes us tired, right? And then glutamate is the on. Too much glutamate causes seizures. So it is like that on switch. So a good way that we can remember this is that GABA, it is inhibitory, helps with relaxation, euphoria, it decreases muscle tension, decreases breathing. It is the treatment for anxiety or seizures. Giving somebody something that is going to increase their GABA, it's what is going to help with that. The way we can remember this is a boring lecture that gabs on and on and on. It puts you to sleep. So GABA puts you to sleep. It is relaxing. It is your off switch. And then glutamate is your on switch. It is excitatory. Too much can lead to seizures. And it also plays a role with learning, memory, and mating. And then histamine plays a role with itching and swelling. We know this, like antihistamines, right, are what we use for allergic reactions. But histamines are also found in the brain and play a role in wakefulness, which is why antihistamines make us sleepy. And then acetylcholine, this plays a role with our autonomic system, so the parasympathetic nervous system. We can see bradycardia, GI motility, salivation, lacrimation, urination, sexual arousal, contractions of our muscles. And then it plays a role with in the hippocampus, so learning, memory, wakefulness, and attention. And too little acetylcholine is actually one of the causes of Alzheimer's disease. So I kind of like this little meme when acetylcholine reminds you of an embarrassing moment 7 years ago. Acetylcholine has to do with our learning and our memory. All right. So when acetylcholine is, I don't know why it's formatting weird like that, but it's okay. When acetylcholine is too low, we can have something called anticholinergic toxidrome syndrome. Again, this is one of those red flag side effects that we were mentioning earlier. So similar to serotonin syndrome, right? We are going to see the dilated pupils. They are going to be hot. They're going to be red. They're going to have tachycardia. They might be shaking. They're going to be confused. Other things you might see that are slightly different is because it's anticholinergic, they're dry. So they're going to have like blind as a bat because their eyes are so dry. They're going to have dry mouth and urine retention because they're so dry. They could also be reaching for objects that maybe aren't there, invisible objects. There are lots of different sources that can cause anticholinergic toxidrome because lots of things act on acetylcholine. There are some examples over here on in the slide. So you can see there's a lot of different ones that can cause this. So again, we look at the medication list to try to figure out the cause. All right, then we have antidepressants. So there is a black box warning for antidepressants that children, adolescents, and young adults taking antidepressants are at an increased risk of suicidal ideation and behavior. This doesn't mean that we don't use them. It's just something we monitor for. And what I've read in the research is typically when this occurs, it's like a deep, dark depression. It is not just like they start taking it and then they might be having like subtle thoughts. It's usually pretty severe. So it's clearly a change. And then also people with bipolar disorder who take antidepressants may be at risk for mania. Antidepressants shouldn't be used with people who have bipolar disorder without some sort of mood stabilization because it can trigger a mania for them. This is a lot of times how people find out they have bipolar disorder, because typically bipolar disorder will present as a depression. That is usually the first phase in the mood cycle, which then will be treated with an antidepressant, because that is typically what we do, which then causes the person to have a mania, which then it can be identified that they have bipolar disorder instead of something like depression or major depressive disorder. All right. So with antidepressants, the first type is serotonin-specific reuptake inhibitor. So this inhibits the transport of the presynaptic neuron, which usually takes serotonin back up into the cell, and there is more serotonin in the synapse. So if you look at this nice picture, we can see the red serotonin channel here, and we can see the SSRI, this elongated orange, is blocking that channel. So that's what it does. It blocks the serotonin reuptake channel. That channel reuptakes the serotonin in the synapse back into the presynaptic cell to like circle it back around. And by doing that, it keeps more serotonin in the synapse space. So therefore it can stimulate the postsynaptic cell more. So the thing that is nice about these medications, and just to point out, up in the right-hand corner, we can see the serotonin with the plus sign. So we know that serotonin-specific reuptake inhibitors are increasing that serotonin. So things that is nice about these is that they're not lethal in an overdose, and they have less side effects than other antidepressants. However, they can take 4 to 6 weeks to reach a desired effect. That is important. You want to know that. People are not going to feel an effect in the first week. It's going to take a month or so. And if they are abruptly stopped, we can see discontinuation syndrome, which can be things like flu-like symptoms, insomnia, nausea, imbalance, and sensory disturbances, as well as hyperarousal. So we want to titrate them down. So the first one is Prozac, and we can see in the bottom corner the typical doses for Prozac, so 20 to 60. This has the longest half-life of 1 week. So when switching from this to another SSRI, we have to be careful, because we can induce that serotonin syndrome, because it is in the body. If their half-life is 1 week, you know what I mean? It's 5 half-lives to really be out of the system. So it's in there for a while. And it can cause in some people an activation leading to a nervousness or insomnia. And in that case, we would switch to a different medication. Then we have Zoloft or sertraline. This has harsher GI effects than other SSRIs, but if we let the patients know to take it with food, that can be helpful. And the typical dose is 50 to 200. Then we have Paxil or paroxetine. This is rapidly absorbed, so it can result in worse side effects because it has the shortest half-life. And it also has higher levels in the blood faster and a higher risk for sexual dysfunction, weight gain, and discontinuation syndrome because of that short half-life. Then we have Celexa or citalopram. This has a high tolerability and works for many people and does not have as many enzyme interactions. However, it can elongate the QTC interval, and we're going to talk about that later, what that is, at higher doses over 40 in adults or 20 in the elderly. And then we have Lexapro, which is escitalopram, with a typical dose of 10 to 20. It's similar to Celexa, but the dose is half of what citalopram is, and it is the cleanest SSRI in terms of enzyme interactions. And then we have Luvox, which is the oldest SSRI, and it's actually only FDA approved for OCD rather than depression. And a typical dose is 100 to 300 a day. So when we think about all of these SSRIs that we just talked about, they all have very similar side effects, and that is going to be migraines, decrease in sex drive, increased bleeding, GI motility leading to either diarrhea or constipation, and nausea. Then we have serotonin norepinephrine reuptake inhibitors. So serotonin, we know, is involved in satisfaction and anxiety, and norepinephrine is involved in energy and focus, both of which can be lost in depression. So it can be helpful for some people who have kind of lost energy and focus. So the first one is Effexor or venlafaxine. The side effects for this, because we are stimulating norepinephrine, people are going to have most likely hypertension, right? Because we're putting them into that like fight or flight state in a way. We're going to see sweating, dry mouth, and that's again because of that norepinephrine on the vascular system. We can also see the side effects of serotonin because we're increasing serotonin. So nausea, insomnia, tremors, and sexual dysfunction. And This one is most commonly associated with discontinuation syndrome, and the dose is 75 to 225 milligrams a day. Then we have Cymbalta, and this is used a lot for patients with fibromyalgia or diabetic neuropathy and premenstrual symptoms, as well as depression. Remeron, so this is technically an SNRI, but it works slightly different than other SSRIs. It also helps to increase appetite. So it's often used with people who have cancer or people in nursing homes that are having difficulty eating. It can be sedating in 50% of patients, so we usually give it at night. And it has a lower frequency of GI disturbances, insomnia, and sexual dysfunction. And it actually helps to decrease nausea, which again is why it's good in elderly and cancer patients, with a typical dose of 15 to 45. So when we talk about side effects, we kind of talked about these already, but we're affecting both serotonin and norepinephrine. So we're going to see all those side effects we saw with the SSRIs because we are affecting serotonin, but then we're also going to see side effects related to norepinephrine. So that insomnia, anxiety or agitation, and sweating. Then we have an antidepressant that is a norepinephrine and dopamine reuptake inhibitor. And there is only one, so this is Wellbutrin. The thing that is nice with Wellbutrin is that it does not affect serotonin. And this is a big one for males, especially, both females too. But because with serotonin, you have the decrease in sex drive and you don't have that with Wellbutrin. If anything, it can slightly increase that. So sometimes people like that. Wellbutrin, it increases the happiness and doesn't have the sexual side effects. It can also help people to stop smoking, and it is not sedating at all. It's actually mildly stimulating for people. Side effects, though, that it can lower the seizure threshold. So we don't use these in patients with eating disorders typically because they already have some electrolyte imbalances. Also, people who have seizure disorders, we don't want to use it with them as well. And then common side effects: headache, weight loss, dry mouth, trouble sleeping, nausea, dizziness, constipation, sore throat, fast heart rate. But these often improve after a week or two. And the typical dose is 150 to 300. It can actually go up to 450. And then we have serotonin antagonist and reuptake inhibitor. So we are increasing and decreasing serotonin in different places. The only one we have for this is trazodone. It's less likely than other antidepressants to cause insomnia or sexual side effects and anxiety. However, side effects do include drowsiness, nausea, dry mouth, and priapism, which would need urgent urology intervention. And this really isn't often used for depression. It's mostly used for sleep. And then we have tricyclic antidepressants. So these are very powerful, I guess, antidepressants, right? But we're affecting a lot of things. And we don't always use the most powerful first. As you can see, we're increasing norepinephrine and serotonin. We're decreasing acetylcholine, histamines, sodium, and calcium. So these have a lot of side effects. The side effects we can see, we're going to have those antihistamine side effects, so sleepiness, drowsiness, sedation. We're going to have anticholinergic side effects, which you can see all those different ones there. They are toxic in an overdose, and they do widen the QTC interval. They also lower the seizure threshold and cause weight gain. So the first one is tofranil. So this is the first antidepressant ever developed. It's sometimes used in children for enuresis, but due to its side effects, it's often not used first line, and the typical dose is 10 to 300 milligrams a day. Then we have anafranil. This is only FDA approved for OCD and is the most effective option for OCD, but it has so many side effects, it's typically not used first line. Elavil, this is used for depression and chronic pain, like chronic back pain, diabetic neuropathy, or pelvic pain. And then Pamelor is similar to amitriptyline with some subtle differences, and the doses are there as well. Then we have monoamine oxidase inhibitors. So these are our MAOIs, and these increase serotonin, norepinephrine, and dopamine. However, the problem with these medications is that if you eat foods that have tyramine, which is literally anything yummy, you can have this hypertensive crisis because it causes the tyramine to build up in your blood vessels and then causes them to constrict. So that is really bad, right? Tyramine is found in processed meats, soy sauce, pickles, beer, wine, cheeses. So it's very difficult for people to not have these things. So these aren't really used as often anymore. Typically people will try ECT before they have something like this if they're like treatment resistant. But if you were to see them, those are the two there. So for MAOIs, the hypertensive crisis, this is a life-threatening and cannot be reversed unless more MAO is produced by the body, because MAOIs inhibit MAO. Hypertensive crisis and death can also occur when MAOIs are taken in conjunction with other medications, and we can see a list of them there. And then symptoms of a hypertensive crisis, we're going to see elevated blood pressure, a sudden headache, facial flushing, palpitations, pupillary dilation, diaphoresis, and fever. The treatment for this is to stop the MAOI, administer phentylamine, and stabilize the fever. Now we're going to talk about antipsychotics. So antipsychotics have a black box warning for elderly patients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk of death. This doesn't mean that we don't use them. We just have to do a risk-benefit analysis. So when it comes to antipsychotics, there are different classifications related to like low potency, mid potency, high potency. And it's really the amount that it affects the D2 receptor. Less potency, we're going to see less Parkinsonian effects. And then more D2 potency, you're more likely going to see those EPS symptoms. For traditional dopamine blockers, so our first generations, and then for second generations, the kind of low potency has less D2 and less that 5-HT2, that's the serotonin. And then the more dose-related D2 potency, the higher potency second generations, we're going to see more of those extrapyramidal side effects, but less weight gain. So we can kind of see the spectrum of things there. You don't need to memorize this, but the purpose of this is just to show like all second generation antipsychotics do not act the same or have the same side effects. There's some differences, and same with first. So our first generation antipsychotics, these are our typicals, and they mostly affect dopamine. And because of that, we're going to see a lot of the movement disorder side effects. So the dystonias, so acute dystonia is when the neck tilts to the side and the eyes roll up. That's like an ocular motor crisis. Akathisia, that is a feeling of raciness within your body. And then pseudo-Parkinsonian, so that is like they look like Parkinson's movements. So you can see like rolling of the fingers like this, kind of shuffling of the gait. And then tardive dyskinesia, that is when you see those mouth movements. So the tongue kind of moves around, the jaw kind of moves around. And those are like more what you're going to see with those. With our second generations, these are atypicals, and they affect both dopamine and serotonin. So they're good at treating both the positive and negative symptoms of psychiatric disorders or schizophrenia, right? The positive and negatives of schizophrenia. But these have more metabolic side effects. So we're going to see things like elevated glucose, elevated lipids, and weight gain, really regardless of what the person is eating. With some of them, like olanzapine, doesn't even really matter what you're eating. You're probably going to gain a lot of weight on it. And then our third generation, these are atypicals, but only with partial D2 antagonism. So we remember a partial antagonism is like it is going to cause antagonism. So I guess it's blocking, but only to a certain percent, not fully. And these are things like our PIPs, RIPs, and RONs. So aripiprazole and brexpiprazole, cariprazine, and lumateperone. And these have less extrapyramidal side effects and minimal metabolic side effects. So this is just going over kind of the typical dosing of these antipsychotics. You don't need to remember this, but it is there for your reference. And it also goes over some specific monitoring that would be needed for these. So you're going to see for most of these, you can see QT prolongation. We're going to talk about that in a second. You're also going to see there's some like agranulocytosis, orthostatic, kind of hypotension can happen, very similar kind of side effects for all of these. And then it also gives you like the different forms. All right. And these are first generations. So our first generation, so Thorazine, this is a low potency, We can see a lot of different side effects. So actually, Thorazine was the first antipsychotic ever invented, so that's pretty cool. But side effects, we can see memory impairments, hypotension, sedation, neurological side effects, and NMS, which we'll talk about, and that QT prolongation, which we're going to talk about as well. We have Haldol. This is a high potency, so it's more selective at that D2 receptor, and because of that, you're going to more likely see those extrapyramidal side effects. Typically, when we give people this, we also give them the treatment for extrapyramidal side effects, especially when this is given as an IM. That's typically why you might see in emergency situations, we give the Haldol with the Ativan with the Benadryl. Sometimes people think, oh, the Benadryl is to help make them sleepy, but that is not true. The Benadryl is actually pre-treating the extrapyramidal side effects that will probably happen because they were given the Haldol. And Ativan can also be a treatment for it as well. The other thing is this can cause prolonged QTC, and we're going to talk about that more. And it is often used in patients with acute psychosis needed during like a restraint. All right, so here's our QTC prolongation. So we can remember in nursing school, we learned the heart rhythm, and our Q is here and our T is here. And what happens is that it starts stretching it out. And the problem is when this gets elongated, it can lead to something called Torsades de points, which means twisting of the points. It is an abnormal heart rhythm, and we can see it over here, and it can lead to sudden cardiac death. So that is not good. We don't want that. So when we talk about a QTC, the normal QTC in men is going to be less than 430, and in women, it's less than 450. Borderline in men is 430 to 450. In women, it's 451 to 470. And prolonged is anything greater than 450 in men or greater than 470 in women. Once we get over the 500 point, it's associated with a 2 to 3-fold higher risk of Torsades de point. And each 10 milliseconds that it increases contributes to a 5 to 7% increased risk. So we don't want this to happen. So we need to monitor for this for people taking antipsychotic medications that can cause elongated QTC. All right, so we remember all the things that dopamine does. And antipsychotics, what they do is they block dopamine in certain parts of the brain. So what this can cause is a loss of drive, a reduction of psychosis, which is what we want. It can induce features of Parkinsonianism. We talked about this earlier, where medically induced Parkinson's disease can be caused by antipsychotics because we're blocking dopamine. With true Parkinson's disease, it's because the individual has too little dopamine. So we're really just causing that through a medication. They can have loss of attention, extrapyramidal side effects, hyperprolactemia. This causes enlarged breasts in males and can also cause like a white substance excreting, which can be really disturbing for some people. So we want to keep that in mind. And then it can also cause neuroleptic malignant syndrome, which is a life-threatening condition, which we will talk about. Looks very similar to the other two we already talked about. So when we talk about extrapyramidal side effects, these are them. We talked about it a little earlier, but this is just a nice slide that goes over all of them. Acute dystonias. So this can appear in hours of being given an antipsychotic medication. It is an acute muscular spasm, usually in the head and neck. It occurs shortly after the initiation of a drug or treatment, usually 50% in the first 48 hours and 95% after 96 hours. Risk factors include a family history of dystonia, prior dystonic reactions, a history of cocaine or alcohol use recently, young age, and male gender. So here are two pictures of acute dystonias. One, you can see the neck is like twisted to the side, and then another one, the eyes are rolling up in the head. You can imagine this is very scary for people. They are aware of what is happening and that they cannot control their body. The Parkinsonianism, so we can see that rigidity, a resting tremor, kind of a masked face, slowing of movements, and cogwheeling rigidity. And they can have emotional blunting, apathy, anhedonia, and be socially withdrawn. When we talk about treatments for these extrapyramidal side effects, we use things like Cogentin, Benadryl, or Simitril. So neuroleptic malignant syndrome, this is one of those 3 big red flag syndromes we were talking about earlier. Again, looks very similar, right? We're seeing the dilated pupils, the agitation, the tachycardia, the hotness, the sweating. And just an interesting fact to note, you don't always need the fever with this. Sometimes, well, usually in books, they say like, oh, it has to be above 104 fever, but you don't always. The treatment for this is dantrolene or bromocriptine. These are just different medication forms. We know these. All right, so our second generation antipsychotics. So these are our atypicals, and they mostly affect dopamine and serotonin. And they have more metabolic side effects. And then our third generation, they only partially affect dopamine and serotonin, and they have much less metabolic side effects. So we can see here the ones with the 3 next to them, those are our like third generation. So Abilify, Brexpiprazole, Vraylar, and Latuda. And then the other ones are going to be our second generation. All right, then we have Clozaril. So this is the most effective treatment for schizophrenia, but it can cause something called a granulocytosis, which is a depletion of the white blood cells, which leads to infection and even death in 1% of individuals. Because of that, there is now stipulations on this medication. So before people can be started on this, they have to fail 2 other antipsychotics. And when they are on this, they have to be monitored through like what's called the clozapine REMS, which requires inputting their ANC values at initiation. It's like every week, and then it slowly becomes more the longer they've been on it. So a normal ANC is between 2,500 and 6,000. The normal number of white blood cells is 4,500 to 11,000. During monitoring for Clozaril, so during the first 6 months, it's every week. During the second 6 months, it's every 2 weeks, and then monthly if the ANC is normal. We discontinue the Clozaril if the ANC is less than 1,000, or if the white blood cell count is less than around 2,000 to 3,000. So again, we can only initiate this if people fail 2 previous antipsychotics. For those who do fail 2 previous antipsychotics, it works 60% of the time. So that is amazing for people. And our serum level, we want between 200 and 700. And signs of agranulocytosis is fever, chills, weakness, sore throat, really any signs of infection. So Zyprexa, this is the second most effective after Clozaril, but it doesn't have that risk of agranulocytosis. It's great as a first-line treatment. However, you're going to have weight gain regardless of caloric intake. So that can be problematic for people. Then we have Risperdal. This is less sedating and can be used in the elderly for this reason. It has a low risk of extrapyramidal side effects. It has a high risk for metabolic syndrome and a higher risk of gynecomastia. Seroquel is similar to Risperidone, but can be much more sedating. You can also go really high on the dosing. Some people can require up to 1,200 a day. Geodone, this prolongs the QTC interval. This one has less weight gain than some of the other second generation antipsychotics, so it can be used often for that reason. If you see a question on the test asking which has less weight gain and it's showing the antipsychotics, it's probably Geodone, unless it's showing a third generation. And then here are our third generations. We have Abilify. So this is a dopamine and serotonin partial agonist, which makes it the third generation. It doesn't completely block the D2 receptor. Instead, it locks them in at 25%. It rarely works for an acute psychotic episode, but it is a great maintenance therapy, and it can help with rumination. The FDA approved it to augment antidepressants. It also works for schizophrenia, bipolar disorder, Tourette's, and irritability and autism. However, there is an interesting side effect with Abilify that it can cause compulsive or uncontrollable urges to engage in like gambling, sexual behaviors, binge eating, and shopping in some people. Rexulti, this is approved for schizophrenia and an adjunct for major depressive. It's the first and only FDA-approved med for agitation associated with dementia due to Alzheimer's disease, not to be used as a PRN. It's like a scheduled medication. Vraylar can be used for short-term acute treatment of manic or mixed episodes, and it can be used to treat both depression and manic symptoms in those with bipolar 1, and it can be an adjunct to antidepressants for major depressive disorder. Latuda or lurasidone can be used for bipolar depression as an adjunct with lithium or valproate. It's used to treat bipolar depression in adults and children, and also schizophrenia in adults. So now let's talk about mood stabilizers. So the first one is lithium. The mechanism of this is unknown, but it is one of the best drugs for suicidal ideation. It is well studied and has a 7-fold decrease in suicide at the therapeutic level. However, it takes time to become effective, anywhere between 1 and 3 weeks. It's approved for those 7 and older. We have to avoid in people who have renal disease. And as we talked about earlier, it has one of the lowest therapeutic indexes, meaning that the dose that is therapeutic is very close to the dose that may harm someone. For example, the therapeutic range is 1 to 1.5 for acute treatment and 0.6 to 1 for chronic therapy. And the toxic level is anything over 2. As far as a nursing implication, you want to make sure people are getting an adequate intake of water. Should be 10 to 12 cups a day. And if sodium intake is reduced or depleted through sweating, fever, or diuresis, the lithium is going to be reabsorbed by the kidneys, which will cause an increased risk for toxicity. Lithium side effects, so we can have some movement side effects. If you start to see tremors, usually the dose is too high. It can be nephrotoxic and cause nausea, so it does damage the kidneys when it's concentrated. So if people are dehydrated, this again is why we need to make sure they have enough hydration. 5% of patients chronically treated with lithium will get renal insufficiency. Lithium can cause diabetes insipidus, leading to further dehydration. It can cause hypothyroid and hypotension, so we can see dizziness, drowsiness, and headache. It can cause pregnancy problems and polyuria. And it can cause QTc elongation, arrhythmia, and pulse irregularities. So when people are taking this, we need to monitor their labs. We need to monitor lithium level, electrolytes, creatine, BUN, CBC, TSH, thyroid panel, and a pregnancy test. When people start to get toxic between 1.5 and 2, we'll start to see blurred vision, ataxia, persistent nausea and vomiting, severe dehydration. Between 2 and 3.5, they'll have excessive urine output, increased tremors, muscular irritability, psychomotor retardation, mental confusion, and giddiness. And over 3.5, they'll have impaired consciousness, nystagma, seizures, decreased urine output, arrhythmias, and cardiovascular collapse. The next mood stabilizer is Depakote or valproic acid. This works to inhibit voltage-gated sodium channels. It has anticonvulsant properties and increases the amount of GABA, giving it a benzodiazepine sedative effect. GABA helps to manage mania as well. Serum levels should be between 50 and 125. We want to avoid in those with hepatic disease. It can cause prolonged bleeding time, drowsiness, nausea, abdominal pain, diarrhea, nausea, vomiting, low platelet count, tremors, tiredness, and hair loss. Black box warning, it can be hepatotoxic and pancreatitis. And contraindicated in pregnancy. So that is a big one. All of the mood stabilizers that are anticonvulsants, people need to use a barrier method because it is contraindicated in pregnancy, and it reduces the way that birth control works, like the pill. It reduces its effectiveness. So a lot of people won't even prescribe Depakote to childbearing age women because it's just such a risk. Tegretol. So this also has a risk of agranulocytosis, but it is much lower than with Clozaril, so it is not monitored as much. There is something called the HLA-B 1502 allele that is highly associated with the outcome of carbamazepine-induced Stevens-Johnson syndrome, so something to be aware of. And again, decreases the effectiveness of oral contraceptives. Lamictal. So this does not affect GABA, and it's better for patients who have bipolar that are in a depressed episode. Side effects. So something with Lamictal we have to watch for is this Stevens-Johnson syndrome, because it starts as a rash and it occurs in 5 to 10% of people. So that's pretty high. And Stevens-Johnson syndrome causes these like blister burns all over the body. And it can be really bad for people. We don't want that to happen. So we start at a low dose of 25 and we go up slowly. if a rash occurs, we stop the medication. Also, people who take this medication have to be somebody who can take it every day, because if they stop taking it, then you are supposed to like start over, and it can also increase the risk of them getting this rash. Then triliptal, this is similar to Tegretol, but it doesn't reduce mood cycling in bipolar. It does not carry a risk of agranulocytosis, but it does decrease the effectiveness of oral contraceptives. That's really like the main point with these. Gabapentin is not FDA approved for treating bipolar disorder. However, it's used off label, and it is often used for neuropathic pain such as diabetic peripheral neuropathy. Lyrica is similar to gabapentin, used for that neuropathic pain. All right, so then anxiolytics. So these mostly increase GABA in some way, causing a calming or relaxation effect, depress the central nervous system, cause relaxation, euphoria, decrease muscle tone, decrease breathing, and they reduce anxiety and are the treatment for seizures. So we have benzodiazepines. These increase the frequency of opening of the GABA channels, and then barbiturates, which increase the duration that GABA channel is open. So with benzodiazepines, we have to remember what goes down must come up. So when we take a depressant like a benzodiazepine for a while, and then people are withdrawing, we're going to see things like anxiety, insomnia, tremors, seizure, hypertension, and it can be deadly. For benzodiazepines specifically, the withdrawal timeline is going to depend on which category of benzodiazepines they were taking, short, medium, or long acting, because each half-life is going to be different. So for example, a short acting is going to have a half-life of 1 to 12 hours. These are often used for panic attacks and for seizures. Medium acting benzo is going to be 12 to 40 hour half-life. And then long acting benzo is 40 to 250 hours. You won't need to remember this for the test, but just for your practice, it's important to know. So side effects, we can see drowsiness, confusion, lethargy, orthostatic hypotension, dependency. Some people have a paradoxical effect. That's like the opposite effect. So you think they're very anxious. You give them a benzodiazepine to help them calm down, and they get amped up even more. They could be having that paradoxical effect, and you need to try something else. And then there can be diseases of the blood, which can happen as a side effect. Again, rare, but it is there. We then have Buspar. So this is not a benzodiazepine or a barbiturate. Its mechanism of action is unknown. It's used for generalized anxiety disorder and is not sedating, and it does not affect GABA. However, the thing with this is that it takes 10 to 14 days to reduce anxiety, so it's not a good PRN medication. Propranolol, this is often used for performance anxiety, but it can also be used for like people who have gone through trauma and they have like that activation, that hypervigilance. Propranolol can be great for that type of anxiety as well. Then we have visceral atarax or hydroxyzine. This is an antihistamine as well as an anxiolytic. It's kind of similar to Benadryl. It can be used for allergic reactions and nausea. It has a low affinity for the mucogenic, that acetylcholine receptor, so it has very little anticholinergic effects. So that's how it's different than Benadryl. You can have some dry mouth and drowsiness though. Then we have stimulants and non-stimulants. So over on the right-hand side, you can see all of the different stimulant medications. There are quite a few. We're not going to go over them all, but the stimulants stimulate serotonin, norepinephrine, and dopamine. There is a potential for abuse. Side effects, we can see growth restrictions in kids, stomach pain, loss of appetite, weight loss, mood changes, feeling nervous, dizziness, sleep problems, dry mouth, and tics and nail biting can be side effects from stimulants. In that case, you'd want to maybe try a non-stimulant medication. When we talk about non-stimulant ADHD treatment, there are really two. So we have Strattera, and we have, sorry, I don't listed in the format, right? But we have clonidine and guanfacine. So they work a little different. So Strattera, we can see side effects very similar to stimulants, but without the stimulating. So they can have that more like sleepish, sluggy kind of feeling. They can have weakness, but we'll see like the weight loss, decreased appetite, things like that. In the clonidine and guanfacine, these affect the alpha 2A receptor. So we can see things like sleepiness, drowsiness, headache, irritability. But the big thing is like, these are blood pressure medications, right? So the low blood pressure, feeling like they're going to pass out. We need to monitor blood pressure before administering. And we don't want to abruptly stop them because they can have a rebound hypertension. And we want to be careful with the dosing of clonidine because it's a weird one. It's like a 0.05 or 0.1 or 0.2. So just to take note of that. And then anti-dementia drugs. So these slow the progression of dementia, but they do not reverse the disease, and they're better if used early in treatment. So anti-dementia agents. So we know that Alzheimer's disease happens because acetylcholine is too low. We can see a healthy brain versus an Alzheimer's brain. There are two drug classes. So we have cholinesterase inhibitors, and we know if we inhibit something, we are making it work less. And cholinesterase is the enzyme that breaks down acetylcholine. So if we're inhibiting it, we'll have more acetylcholine. And as the disease progresses, the drug benefits don't work as well because the body just stops producing acetylcholine. So even though you're inhibiting the enzyme, there's just not enough acetylcholine. These are acetylcholinease inhibitors. We can see there are lots of side effects for them. So risk of psychotropic drugs in pregnancy. So there can be problems with appetite. It can have agitation and sedation, premature labor, drug discontinuation syndrome, and teratogenic effects. Risks of not taking drugs during pregnancy can lead to reoccurring symptoms, adverse effects on the mother and baby bonding, and poor maternal self-care. We always want to check pregnancy status before starting a woman of childbearing age on psychotropic medications. We need to make sure that they have folic acid to support neuronal tube development during the first month that woman is pregnant. And they should take 0.4 to 0.8 milligrams of folic acid a day. So when we talk about FDA pregnancy ratings, so A is controlled studies show there's no risk. B is that there's no evidence of risk in humans. C is risk cannot be ruled out. D is positive evidence of risks. And X is absolutely contraindicated in pregnancy. Teratogenic risks of common psychiatric medications. So benzodiazepines can lead to cleft lip and floppy baby syndrome. Carbamazepine can lead to neural tube defects. Lithium can cause an Epstein anomaly. And then Depakote can have those neurotube defects, specifically spina bifida, atrial septal defect, cleft palate, and possible long-term deficits. All right, and that is the end. Thank you so much, and I'll see you guys next time. Bye.